Now we're going to talk about the cardiac cycle. So first, a little bit more terminology. Mechanical physiology refers to the process in which blood adequately fills the chambers of the heart, then pumping the blood that's in the heart outward, so creating a force, a flow of blood. So remember, cardiac muscle contracts as a unit. It's mainly because of the gap junctions. To have a coordinated contraction, so you want both atria contracting at the same time and both ventricles. So what we call a heartbeat. And if you actually look at the arrangement of the external cardiac muscle, it kind of has a spiral pattern to it. Ringing action. So you want to imagine the ringing starts at the apex of the heart. So again, we're forcing blood upward towards where it can enter the pulmonary circuit and the systemic circuit. So fluid creates pressure when it's contained within a cavity. And so pressure changes are caused when the heart contracts and when blood is moving. And valves can help direct blood flow by not allowing it to go backwards and also by helping create these pressure differentials. So all the events that take place between one heartbeat and the next, we call that the cardiac cycle. So we're going to talk about this in some great detail. So when we're looking at the cardiac cycle, the chambers that are the most important are going to be your ventricles, because again, when they pump blood, that's how it gets moved to the systemic or the pulmonary circuit. So just to recap, it's going to go through the pulmonary circuit, it's going to leave the right ventricle, go up the pulmonary trunk, through the pulmonary arteries, through the pulmonary circuit. And if it's leaving the left ventricle, it's going to go up the aorta through the systemic circuit. So there's two events that we talk about with the ventricles. So in this first picture, we have ventricular filling. So this is what happens during diastole. Remember, diastole is what we refer to as relaxation. So when it's relaxing, it's able to fill with blood. Naturally, as blood enters the atria, gravity, it's going to come in the ventricles as well. And then, of course, atrial contraction helps move more blood into the ventricles. And then ventricular ejection, which is how much blood is ejected while they are contracting. So you'd basically be talking about the amount of blood that would be leaving the chamber and entering, in this case, the aorta to go into the systemic circuit. So that's going to occur when the ventricle's contracting. Again, systole is the term we use for contraction. So just like air molecules, like an aerosol can, move from high to low concentration, blood moves from pressure gradients, from high to low pressure. So as the ventricles contract and relax, contraction increases pressure, relaxation decreases pressure. That causes blood to push on the valves and they will open and close. And again, valves really help direct the flow of blood. When ventricles contract, their pressure, so all of this basically again goes back to pressure. So you have to see, where is the pressure greater, where is the pressure lower. Okay, wherever you have a higher pressure, blood's going to be moving from the higher pressure to the lower pressure area. So when the ventricles contract, contraction causes an increase in pressure. It's going to be more than what's in the right and left atria and in the pulmonary trunk. So you want to alleviate that high pressure. So we're going to take blood to the next place once it's in the ventricles, which of course would be your pulmonary trunk and aorta. So to do that, you have to have valves that open, that allow blood to enter those vessels. So the force of pressure upward actually forces shut the AV valves, and then that same force will open your semivalves. Okay, so as we see here, as soon as the ventricles contract, the massive contraction, the upward flow of blood, that forces those valves closed, Remember, right before the actual ventricles contract, these papillary muscles contracted. So when we force this closed, we don't have to worry about it involuting. And so pressure builds up. It's not allowed to go to the atria. So of course it's going to exit out. In this case, we're talking about the left ventricle. So it would go out the aorta. So it's going to pass the aortic semilunar valve. The force of blood upward as it hits this left AV valve or mitral or bicuspid valve is actually the lub in the lub-dub sound, or what we call S1. So the ventricles relax, pressure is decreased. So the opposite occurs. Now the pressure in the ventricles is lower than in the atria, the pulmonary trunk, and the aorta. So that's going to force the aortic and pulmonary semilunar valves closed. The high pressure from blood returning to the right atrium and left atrium forces your right and left atrioventricular valves open. So now blood can start to fill the ventricles. Okay, so naturally, as the ventricles are relaxing, so are the atria. Blood is always returning to the heart. So the gravity, the fact that you have more blood here, you have less blood here because it just left. You have a higher pressure here, lower pressure here, so we move from high pressure to low pressure. And again, we will begin the ventricular filling. Now, of course, as soon as the pressure is less in the ventricles than it was in the aorta, that's when those semilunar valves closed. And as blood tries to go backward, because you no longer have the force forcing it up, that's actually the second sound that we hear. That's S2 or the dub. So doctors use a stethoscope to be able to listen, or we call auscultate, the heart sounds, so they can hear more distinctively these different events. Under normal conditions, when any of the valves are open, you're really not going to hear that sound. You really only hear the sound when the valves close and the force of blood are hitting those. So again, that's what the S1 or the LUP and the S2 or the DUP sounds are. Typically, S1 is a little longer and louder because this is when the ventricle's first starting to contract, where S2 is going to be a little softer and typically not last quite as long. So if you look for the placement of these valves, all of the heart valves are very close to the mediastinum, the very center of the chest. And so we actually move slightly off to the side, away from bone. Bone can help block some of these vibrations that we're actually trying to hear the valves from. So typically you're going to see that these placements are going to be between ribs. So these first two placements, which are of the aortic semilunar valve and the pulmonary semilunar valve, are going to be between the second intercostal space. Intercostal refers to the space between the ribs. The other two, sometimes they change it. This book happens to have them here and here. They're always in the fifth intercostal space. The tricuspid is always further right than the mitral or bicuspid. Some doctors will just move this over right here to the other side of the sternal angle, and then they'll leave the mitral valve just slightly over. It just depends on the doctor. So how you can help remember that it's aortic valve, pulmonary semilunar valve, tricuspid or right AV valve, and then mitral, bicuspid, or left AV valve is all physicians take money. So a lot of times when they're listening for sounds, they're actually listening for something wrong, possibly with the heart. We call a heart murmur, which is when blood flow through the heart isn't flowing in one direction. It can be turbulent. Typically, this indicates that something's wrong with the valve. It could be that the chordae tendineae are not properly holding it down. There could be a small tear, a hole, or there actually could be an opening between the atria or between the ventricles. A lot of children will have heart murmurs and they don't necessarily have defects. A lot of times they will grow out of them. It'll just be something that the physician will watch. If you want to listen or if you want to watch a video, this is going to show blood flow through the heart, and it's going to show as the blood hits the valves, you hear the sounds. It's kind of nice, it puts it together. Okay, so again, each cardiac cycle, you're going to have a period of relaxation. Again, the term we use for that is diastole, and a period of contraction, or what we call systole, in each chamber of the heart. And again, when we look at, there are 4 chambers of the heart, but the 2 atria and the 2 ventricles are going to be synchronized. So what allows the atria and the ventricles to contract at different times is the fact that we have that delay at the AV node, which again allows us to make sure that blood is moving through the heart one direction. And basically, when one ventricle is contracting, the other ventricle is contracting. So blood will be moving into the pulmonary and systemic circuits at the same time. We can actually divide the cardiac cycle into 4 phases. You definitely need to know the order of these phases. And you can kind of mix them around because it's a cycle, it repeats itself. So we're going to talk about filling, we call isovolumetric contraction, ejection, and isovolumetric relaxation. Okay, so first we're going to talk about the ventricular filling phase. Kind of self-explanatory in that we are filling the ventricles. So this is actually showing the first part. So remember that we constantly have blood, deoxygenated blood, returning from the superior and inferior vena cavas into the right atrium, and oxygenated blood entering the left atria from our right and left pulmonary veins. So as the atria fill with blood, that increases the pressure, which are going to force the atrioventricular valves open, allowing the ventricles to start to fill with blood. They will only be filled about 70% until the atria actually contract. And remember, we use the term systole, so then the atria contract. It's going to force any remaining blood to enter the ventricles. So now the ventricle is filled with blood. Keep in mind, because the ventricles haven't contracted yet, the pressure is low, relatively low in the ventricles, so our semilunar valves are still shut. You will never see the AV valves open the same time as the semilunar. The next part is isovolumetric contraction. Iso is the same, volume is the amount. It's because we're actually not ejecting any blood. The ventricles are keeping the exact same amount of blood that they have. So the atria capped it off with maybe about 20-30% more. Here, because the ventricles just started contracting, the pressure is still greater in the pulmonary trunk and in the aorta than it is in our right ventricle and our left ventricle. So as long as the pressure is greater here, these valves will stay closed. As soon as the ventricles started contracting, remember that naturally our AV valves closed and they're held closed by the chordae tendineae. So again, blood cannot go anywhere. That's why it's isovolumetric. And if the ventricles are contracting, the atria are relaxing at this point. And you, of course, always still have blood returning, okay, from the same areas that we talked about just before. I want to talk about another term here. We were looking at isovolumetric contraction phase. So we have the EDV. So the end diastolic volume is the amount of blood that is in the ventricles at the end of their relaxation, or basically right before it contracts. So this is the amount that possibly could be ejected. And in lab, I know I talked about this, we will talk about it a little later, the actual amount that's ejected, that is our stroke volume. Okay, the third part, ventricular ejection. So the ventricles are still contracting, however, this time the pressure is greater in my ventricles than it is in the aorta or the pulmonary trunk. And that's what forces these semilunar valves open. So now blood is ejected from each ventricle, from the right ventricle into the pulmonary circuit, and from the left ventricle into the systemic circuit. As blood leaves the ventricles, pressure drops. So as soon as pressure is lower in these ventricles than in the aorta and pulmonary trunk, the semilunar valves closed. So this is isovolumetric relaxation. Again, isovolumetric, we're not changing the volume of the blood in the ventricles. As the atria continue to fill with blood, the pressure is going to rise, and eventually that will force these AV valves open. And then, of course, we will go back to ventricular filling. There are a few terms that I want to mention here. We have what we call the end-systolic volume. This is the amount of blood that remains in the ventricles after contraction. So remember, systolic is contraction, obviously the end. So notice during rest, we do not eject all of the blood. Okay, there's definitely some that remains. Okay, so this simple chart just kind of helps to understand when each chamber is in relaxation, contraction, which valve is going to be open or closed. And again, the primary chamber we're talking about when you're talking about circuits or pressure is the ventricles. This is nice. This is a chart that basically shows several things together. It shows the pressure, which we measure blood pressure in millimeters of mercury. And you can see when it rises or goes down during those different stages. So these next slides are basically there to help piece this through for you. So again, you can see the three components that we talked about, and you can kind of match it up with what's going on. If I try, I really would like to try to do this in class with us just to review right before the exam. So just to generally kind of go over all the steps, and again, you do have to know this. So the first part is ventricular filling. Okay, so naturally they fill by about 70 or 80% just by the gravity of blood moving from the atria to the ventricles. Then the atria will contract. That's going to continue, basically top off the ventricles with the last remaining blood. Now the atria will start to relax diastole as the ventricles are going through systole. So as soon as the ventricles start to contract, we're going to close those atrioventricular valves. Okay, now isovolumetric contraction. So isovolumetric, we're actually not having blood leave the ventricles, but we are increasing the pressure. As the pressure rises above that that's in the aorta and pulmonary trunk, that's going to force the semilunar valves open, so blood can now enter the pulmonary and systemic circuits. So the ventricle is ejecting blood. So again, this amount would be your stroke volume. Then the ventricles will relax. So again, the amount of blood that remains in there is the end diastolic volume. The pressure decreases. That's going to force the semilunar valves open. Isovolumetric relaxation. Again, I'm not changing the volume of the ventricles. All valves are closed, but my atria are starting to fill with blood, and eventually that pressure will force the AV valves back open. Okay, so to review, what is occurring during isovolumetric contraction? So contraction, you're going to have an increase in pressure. Iso means the same. Again, the volume inside the ventricles isn't moving. So these are when the ventricles are squeezing, contracting, but there's no movement of blood. So the amount of blood in each atria stays the same. Is blood still returning from the rest of the body in the atria? Yes, it always is, so that can't be true. The semilunar valves are open and the AV valves are closed. If any valves were open, blood would be moving, so that's not true. The point at which all blood has been ejected from the ventricles, again, blood is not moving, so anything ejected is not true. Both atria are ejecting blood. Where do atria eject blood? Into the ventricles. Again, no blood is moving, so that is not true. All 4 valves are closed. That makes sense. More blood flows through the coronary arteries during ventricular diastole than systole. Okay, so diastole is during relaxation. Systole is contraction. Okay, if the heart is contracting, those coronary vessels that sit just outside the myocardium are going to get squeezed on. If they're getting squeezed on, they're not going to hold as much blood. So this is true. More blood is going to flow when there's not pressure outside those vessels, and that's going to be when the ventricles are relaxing. Isovolumetric contraction and isovolumetric relaxation both occur when all 4 valves are closed. That is true. Again, isovolumetric, the volume is not changing. The volume's not changing in the ventricles. Then that means the valves are all shut, and that's why the blood is stuck inside the ventricles. So that is true. Which statement is not true regarding heart sounds? I actually took out S3 and S4, so we're just going to go ahead and take out those. S2 is louder and longer than S1. That's not true. S1 is louder and longer. S1 is caused by the closing of the AV valves. That is true. S2 is due to the semilunar valves closing. That's also true. Okay, now we're going to talk about cardiac output. A lot of times for short, if you see capital CO, that's referring to. So earlier we mentioned the cardiac cycle, which is the beginning of one heartbeat to the beginning of the next. How often it beats, the frequency is what we termed heart rate. So the heart on average goes 60 to 80 cardiac cycles per minute or beats per minute. Heart rate, why we would increase or decrease heart rate would be to increase or decrease the amount of blood going out to tissues. And that essentially is what cardiac output is. It's the amount of blood that is ejected from the heart every minute. So all throughout the body, of course, that would include both pulmonary and systemic circuits. So there's 2 factors. If you want to increase the amount of blood going out to the body, you could increase heart rate, keep stroke volume the same. You could keep heart rate the same, increase stroke volume, or you could increase both. Okay, all of that would give the same effect, which would be to increase cardiac output. Of course, if you wanted to decrease, then you would just decrease the others. So we are going to talk about how these variables can be affected. Okay, so to determine cardiac output, again, we need to figure out stroke volume. So we can figure out stroke volume, which is the amount of blood ejected per beat, by taking the amount of blood at the end of the contraction and subtract that ESV from your EDV, the amount of blood that's at the end of the relaxation, which of course is before it contracts. In the average heart, the resting stroke volume typically is about 70 milliliters. And again, that's per beat. So you can take so on average, you're saying the average person has about 120 milliliters for the end diastolic volume. Again, at rest, they are not going to pump all the blood out, so they'll have 50 milliliters of blood still remaining after the ventricles have contracted. So again, the amount of blood that's actually moving through the pulmonary and systemic circuits would then be stroke volume, which in this case, 70 milliliters. Okay, so again, to figure out cardiac output, we are simply going to multiply the heart rate by the stroke volume. So the heart rate is beats per minute. And I actually want to show this a little different, beats per minute. And then you have the stroke volume, which is the amount of milliliters per beat. So what happens is when one's on the denominator, one's on top and bottom, basically they cancel out. So what you're left with is milliliters per minute. Again, how much blood per minute, which a lot of times we will go ahead and convert that to liters. Remember, there's 1,000 milliliters per liter. So in this example, 72 beats per minute, which is average, times the average stroke volume gives about 5,400 milliliters per minute of blood that the heart is pumping through the body. So just over 5 liters of blood a minute, which if you remember back from the blood chapter, we said the average adult is about 4 to 5 liters of blood. So basically what we're saying is the normal adult can basically pump the entire volume of blood through their body every minute, which is pretty impressive. So stroke volume, again, typically is 70 milliliters per beat. However, there's a range. So when you're really at rest, you would want it to be low because you don't have to have as much blood going to your other tissues. Or when you're exerting yourself sympathetic, you would want it to be much higher. However, the exact amount of volume is difficult to measure. So typically, we look at it as a fraction. What percentage of blood was actually ejected? So the normal ejection fraction is about 50 to 65%. Why is it that number? Again, this is at rest. You want there to be a difference when your body needs it. Okay, so typically it's going to be lower. This value should also be equal for each ventricle. That's hard for some people to understand, especially because we said the left ventricle is much thicker walled. It's thicker walled because it pumps blood through more vessels, so it has to have a greater pressure. It does not pump more in the amount per beat. Remember, everything from the pulmonary circuit gets pumped to the systemic circuit, and eventually everything from the systemic circuit will be pumped back into the pulmonary. So those need to be equal. If one or the other are high, they're going to cause issues, which we can discuss later. There are 3 different factors we can look at that can actually affect our stroke volume. Okay, so first of all, preload. This refers to the amount of stretch that's occurring in the cardiac muscles before they contract. So the more blood that's in the ventricle, the more stretching, and naturally the more that it's going to want to recoil. Okay, so we use the end diastolic volume. That's the amount in the ventricles right before contraction. So the higher that value, the higher the preload. Therefore, the higher the stroke volume, so the higher the cardiac output. Okay, 2 different factors can affect your end diastolic volume. The amount of time the ventricle spends filling. So if it's too close together, you're not going to have enough time to adequately fill with blood. And also how much blood is getting returned back to the heart. And we call that the venous return. So your end diastolic volume will increase the longer the ventricles are relaxing, because that's the more time that your heart has to fill. And it's also going to increase with the more blood that's returned to the heart. So we talked about tachycardia earlier, where that's going to be an increase of 100 beats per minute or faster. What type of effect is that going to have? Well, it's going to reduce the filling time. So your EDV is going to go down, which is going to make your stroke volume go down, which is going to make the cardiac output go down. So the relationship between the preload and stroke volume, we explain this using the Frank-Starling law. So know that that represents the relationship between these two. So again, we basically say the more stretch, which we're showing here in this outward force, because the heart's being filled with blood, the more naturally it's going to recoil. Kind of think about a rubber band. The more you stretch it, as long as you don't overstretch it, the more it's naturally going to recoil. The purpose and why the heart is made of this, part of it is because, remember, there's collagen fibers that form the fiber skeleton of the heart. That's to actually allow some elasticity. So as the heart's filling with more blood, you're stretching it more. Naturally, it can recoil to make sure that more blood is actually being ejected. So if you have more blood returning to the heart, the more it's going to stretch, the more you need to eject. More in, more out. That makes sense. Okay, if you would like to watch, if that's kind of tricky for you, this is a great, again, Khan Academy is excellent. We also have another video kind of similar. Other factors that influence stroke volume. So we talked about preload. Now we're talking about contractility. So this is the heart's ability to contract or basically generate tension. And here we're not talking about stretch. Okay, with stretch that was preload. This again can be difficult to measure, but we can measure how fast or the velocity that blood is being ejected from the ventricles. And increasing the contractility or the ability of the muscles to shorten. Shorter sarcomeres means greater pressure being exerted on the blood inside. The more blood that's ejected. So again, that stroke volume, the more blood that's ejected. And so we're going to decrease the amount of blood that's left after the end the ventricles are contracting in systolic volume. Decreased contractility will have the opposite effect, of course. Decreasing stroke volume, so you have less blood being ejected, so you're going to have more blood still in the ventricles after contraction, assuming that we're not changing the other variables that we're talking about that can also affect stroke volume. Okay, so typically if you want to increase cardiac output, again, the two variables are heart rate and stroke volume. The quickest way to do that would be to increase them both at the same time. So generally, we do see that. We have different agents, basically things that are going to act on these variables. Anything that affects the contractility, we call that an inotropic agent. So factors that do anything with the heart rate, such as sympathetic neuron stimulation. So think you're in fear of your life. Yes, your skeletal muscles, your brain, your lungs are going to need more blood. So you would want to increase cardiac output. You're also going to affect how much your cardiac muscles are contracting. That's basically what contractility is. You want them to contract their full ability. So you're increasing the force of contraction. How hard you're ejecting blood with each beat. And again, if you increase the force of contraction, that's also going to increase your stroke volume. When the heart rate gets too high, contractility actually decreases because the heart, if it's beating too fast, you're not giving it enough time to get the oxygen and nutrients that it needs, and you're not allowing the heart enough time to fill, so it's actually not pumping as much blood out. You're not going to be stretching it as much, so the preload's going to decrease. You're not going to stretch it as much, so it's not going to want to contract. So both of those are going to decrease the stroke volume, which again decreases cardiac output. And again, this is why tachycardia can be dangerous, because the heart rate's too high. You're not allowing it enough time to fill with blood. It doesn't matter if you can contract it fast if you don't allow it to fill what you're trying to pump out. Okay, the afterload, third factor that affects stroke volume, refers to the force that the ventricles must overcome to eject blood into the arteries. So it's basically the pressure that's inside of those arteries, the pulmonary trunk and the aorta. And those, of course, are the main vessels of the pulmonary and systemic circuits, the first vessel off the heart. So if the afterload increases, that means the ventricles must create a greater pressure to allow blood to actually be ejected. So things that would increase afterload would be an increased blood pressure. So an increase in afterload will cause a decrease in stroke volume, because again, it's harder to eject blood against a harder pressure gradient. And obviously, if you decrease the afterload, if you decrease the blood pressure, then you'll be able to eject more blood more easily. If you want to watch a video on afterload. Okay, so again, just kind of reminding us of the three factors that affect stroke volume. So cardiac output is stroke volume times heart rate. So right now we're talking about the three variables of stroke volume. So preload is determined by how much blood is basically entering the ventricle, how much blood we load it with before it contracts. Contractility is basically how good can those cardiac muscle cells contract? How hard can they squeeze? And then the afterload refers to basically the pressure that must be overcome by the ventricles. So again, this is kind of putting it together. So if you have a high preload, so that means a lot of blood that's filling that ventricle, that means you're going to increase the amount of blood at the end of relaxation diastole. So that would increase your stroke volume, therefore increase cardiac output. If you increase contractility, the ability of the heart to contract, you're going to decrease the end systolic volume. How much blood is in the heart at the end? Remember that stroke volume is how much do you start with before it contracts versus how much is left after it contracts. So if you can affect either one of those variables, you can affect stroke volume. Afterload, the less the pressure, which is afterload, that the ventricles have to overcome where they're pumping it, the lower the end systolic volume, and again, the higher the stroke volume. So of course, this is consequently the opposite. You can work through this. Afterload is increased by any factor that restricts blood flow through your arterial system. Arterial system is going to affect your systemic circuit. So if you have high blood pressure, hypertension, aortic stenosis, your aorta is basically kind of hardened and it loses its ability to stretch, or you have circulatory blockage, possibly a thrombus in blood vessels or even embolus. There are other causes. One off the top of my head would be edema. If you have a lot of fluid accumulation in the outside tissue, that's going to put pressure on the blood vessels and restrict blood flow. So if the afterload is too great, the ventricle cannot eject the blood. So again, you don't need the pressure where it's going to be too high. And that's essentially what happens is when people have high blood pressure, that means the pressure inside the aorta is higher. So that means that the left ventricle has to increase the amount of pressure to open the aortic semilunar valve. So it has to work harder. So the heart will increase in size, but the heart can only increase so large, and then that actually becomes a problem on its own. Then heart attacks are much more common. So long-standing stress increases the preload and afterload, and that's basically how you get the enlarged ventricles. Again, your heart's having to work harder to keep blood going through your cardiovascular system. So your ventricles specifically enlarge. Hypertrophy is anything that enlarges. Your heart is having to work harder, so more cardiac muscle tissue has to develop. So if specifically you see the enlargement more on the right side, remember from the right side of the heart, we're going to be pumping into the pulmonary circuit. So that typically indicates that there's high blood pressure in the pulmonary circuit or some type of respiratory disease that's building up pressure and you're having a problem exchanging gases. Where if it's from the left ventricle pumps into the systemic circuit, so that means you have high blood pressure within that circuit. So again, the heart enlargement will only increase to a certain point. Okay, as the heart continues to enlarge, the actual chambers of the heart are decreasing as well. Okay, so you are decreasing the amount of space, therefore decreasing the amount of blood that can be ejected out. Again, the heart's constantly having to work harder. It can't meet the needs of the body, so it continues to try to work harder, and typically heart attack, heart failure will occur. So again, why is tachycardia such a negative cardiac efficiency? This is when the heart rate is too high, and it happens so frequently that again, you do not allow the heart to have ample time to fill with blood. The heart's not full with blood, it can't adequately pump blood into your pulmonary and systemic circuits. So of course we talked about with cardiac output, we were looking at stroke volume and heart rate times. So now we're going to focus on heart rate and the effects, the agents that affect heart rate. So stroke volume, those were inotropic effects. With heart rate, they are chronotropic effects. These are things, heart rate is determined, remember, by the pacemaker of the heart, which is typically the sinoatrial node. So anything that affects that node, okay, can stimulate it, basically, is going to increase your heart rate. So we have, again, sympathetic neurons. We're going to talk about specific hormones, and then, of course, anything at an elevated body temperature that allows enzymes to work faster. and it includes the electrical activity of the heart. So that's naturally going to be faster as well. A negative chronotropic effect would be something that decreases activity of the SA node, therefore would decrease heart rate. And that's going to be when we're talking about resting, parasympathetic nervous system, if you're very cold as well. Again, blood holds body temperature, so if one's cold, you're not going to want to pump the temperature away from the core of your body. So the heart is autorhythmic. It's set by the SA node, and it can contract on its own. We still regulate it. We need to increase heart rate and decrease heart rate depending on the body's needs at the time. If you're in rest, parasympathetic mode, versus the things that you need in sympathetic or fight or flight. So again, the two organ systems that regulate everything in the body are the nervous and endocrine systems. So we're going to talk about how these can affect heart rate as well as stroke volume. Okay, so remember that in the autonomic nervous system, we have parasympathetic and we have sympathetic. Parasympathetic is rest and digest. So when that's going on, we're going to lower cardiac output. So you want to lower stroke volume, lower heart rate. Sympathetic, we want to increase activity of the body. So you're going to increase cardiac output. You can do this by increasing stroke volume and by increasing the heart rate. Okay, so of course, sympathetic, we're going to want to increase, just reminding us that the sympathetic ganglia are very close to the spinal cord. So the neurons are going to release the hormones associated with sympathetic. So those are our catecholamines, norepinephrine, which is 80%, and then also epinephrine. So norepinephrine is going to increase cardiac output by actually increasing the chronotropic effects, things that affect heart rate, versus inotropic effects, things that affect stroke volume. So on the heart rate, it actually increases how quickly the SA node sends those action potentials. So it's going to fire about 180 to 200 times more per minute. For typically average, it's about 60. It also increases the amount of calcium into muscle cells, where calcium is always the final trigger for muscle contraction to occur. So more calcium concentration, the greater the cardiac muscle cells will contract. Therefore, they can eject more blood, so you see an increase in stroke volume. So by increasing the stroke volume, increasing the heart rate with the SA node, we've increased cardiac output. Parasympathetic, the main nerve is going to be the vagus nerve, cranial nerve 10. These nerves release acetylcholine. At the SA node, acetylcholine has the opposite effect that it does in skeletal muscle. It actually decreases action potentials that are being sent. So this is a negative chronotropic effect. It's decreasing heart rate. So it slows the heart rate, can temporarily stop the heart. Obviously not enough to cause issues. Vagal nerves innervate atrial muscles more than they do the ventricles. Therefore, parasympathetic has a lot greater effect on heart rate and therefore chronotropic, and very little effect on inotropic, or things that affect stroke volume, because that's affected more by the ventricles. Okay, so we talked about neural regulation, discussing hormonal regulation of cardiac output. So the adrenal medulla is neuroendocrine tissue, where we release norepinephrine and epinephrine from. We just discussed that epinephrine and norepinephrine will both increase the heart rate and increase the stroke volume by increasing contractility, which will increase cardiac output. So these hormones obviously are the same that are released by the neurons of the sympathetic nervous system. Other hormones that also have positive inotropic effects, so they're going to increase inotropic as stroke volume and chronotropic heart rate, are going to be thyroid hormone and glucagon. So remember, thyroid hormone increases the activity in every cells, therefore increasing cardiac muscle cells, increasing contractility, which increases stroke volume. Increasing metabolism of cells also is going to help increase the heart rate. Glucagon helps to raise blood sugar. More sugar can be converted to more ATP, so the heart can work harder. What's also plays a role in cardiac output is the actual amount of blood that we have, which the main constituent of that, 90 to 92%, is water. So as we just discussed in the endocrine system, hormones that affect the amount of water that the body can retain are going to increase blood and therefore blood pressure. Increasing the amount of blood, also it's going to increase the preload. Remember, that's the amount of stretch that the heart gets. The more blood that's returned to the heart, the more the heart's going to be stretched and the more blood will be ejected when it contracts. So that will increase stroke volume. So aldosterone, remember, helps us retain more salt. Antidiuretic hormone helps us retain more water. Both are going to decrease urine output, therefore increasing blood volume. Increasing blood volume helps to increase cardiac output. Of course, remember the antagonistic hormone to that is ANP, or atrial natriuretic peptide. This is released by the right atrium when it's being stretched too much, so when the preload is too high. So that means blood pressure is too high, so it's going to lower cardiac output. It would do this by lowering heart rate, lowering stroke volume, and lowering blood volume by increasing urination. Other factors that influence cardiac output, how many electrolyte stuff that you have in the fluid. So calcium is needed for muscle contraction, and potassium leaves the cell, which causes repolarization. So both of these in the extracellular fluid, if the amounts are too high or too low, can increase or decrease the ability of the heart to contract. Body temperature as well, as I mentioned earlier, the SA node, the pacemaker of the heart, fires more rapidly at higher temperatures, just like the body, all the body metabolism. Chemical reactions that are occurring in the body occur faster. The lower the body temperature, the lower the cardiac output. And of course, when someone's freezing, this is actually detrimental, because if you decrease the amount of blood going to the tissue body cells, those tissues start to die and become necrotic, and the body will continue to lose temperature. Other things that influence cardiac output, these we have more control over. Your age, obviously you don't. Physical fitness for sure. The more that you work out your heart gets stronger, and your heart rate, resting heart rate, will decrease, because as your heart gets stronger, your stroke volume will increase. So your heart will not have to beat as often or as hard to get as much blood to the rest of the body. That's why trained athletes have a very low resting heart rate. It could even be lower than 50, technically considered bradycardia, but they really don't have too slow. It's just that their heart is that adequate. This basically puts all the different factors together. I would really like to review this tomorrow in class or before the test, just to kind of go over again how all of these affect stroke volume and or heart rate, and therefore cardiac output. Okay, cardiac reserve. This is the difference between what the cardiac output is at rest or during parasympathetic mode and the maximum amount that the heart can pump out, generate, which of course would be in sympathetic mode. So in an average healthy person, the cardiac reserve is about 4 to 5 times the resting value. So it's 4 to 5 times higher the amount of blood your heart can pump per minute than what it is at rest. Now keep in mind that these numbers couldn't be kept that high, for prolonged periods of time. Heart failure is defined as any condition which does not allow the heart to keep up with the demands of the body. So it can include a reduced contractility. So the cardiac muscle cells itself just cannot contract as much. It can be from myocardial ischemia, which is when your heart tissue is not getting enough oxygen, or myocardial infarction. This is a heart attack. Basically, you have blockage of one of the coronary vessels. Again, you're not allowing the heart muscle to get oxygen. A valvular disease that would disrupt the flow of blood, or any actual disease of the heart muscle itself, like overgrowth, cardiomyopathy, or an electrolyte imbalance, which could hinder the depolarization, repolarization ability of the cells. Typically, heart failure, of course, you'll have decreased stroke volume, which over time is going to, of course, directly decrease this cardiac output. So the heart naturally is going to have to increase heart rate. That's actually something you can see in someone that might be close to heart failure, so their heart rate's going to be extremely high because they're trying to overcome how low the stroke volume is. Okay, so again, it really depends on the side of the heart that's affected. So if it's a problem with the left ventricle, then blood moves into the left ventricle from the pulmonary circuit. So typically you're going to have blood that accumulates back, so you congest the lungs. So we call that pulmonary congestion. This will increase the pressure in all of your pulmonary vessels, and therefore increase the amount of fluid that's outside of the lungs. You'll start to have pulmonary edema, which makes it harder to bring in more oxygen to the body. And eventually, if you're backed up in the lungs, that's going to start to affect the systemic circuit as well. So you can have systemic congestion. And we'll talk about edema on the next slide. So if both the right and the left ventricle are failing, then that means you're not pumping as much blood out. You're not having as much blood pump in because your pressure is low. So you have fluid that's accumulating outside of the vessels. That's what we call peripheral edema. So you'll start to have puffy, you can feel fluid outside, typically if you gently press on a person's skin. So you're backing up, again, the systemic circulation. So we call that systemic congestion. Just right-sided failure, immediately you're going to see systemic edema. All of waste-filled blood enters from the right side. So if it's inadequate to pump, it's going to slow the return, increase the amount of edema. Left-sided will cause systemic edema, but it takes longer. So first that person would have pulmonary congestion, then it would move to systemic edema. This backs up fluids in the capillaries into tissues. Again, you have more peripheral swelling. This is dependent edema. So again, this is really not a problem with the lymphatic system. This is because of the inability of the heart to move fluid properly in the body. A lot of times you again have it more the lower limbs because you're fighting gravity, because again the pressure is very low for the circulatory system in the person's body. Unfortunately, peripheral edema also puts more pressure on the kidneys. The kidneys will retain more fluid, trying to take the pressure off of the heart. They're trying to accommodate again for that low cardiac output. So treatment is typically, of course, the person's body is trying to increase cardiac output. So how can you do that? If they lose weight, every pound of fat has about a mile of capillaries that your heart's having to pump fluid through. You make sure the person exercises regularly so the heart muscles are strong, so they have the ability to increase contractility when needed. Also making sure that their sodium levels do not get too high. They're drinking enough water, not too much if their blood pressure is too high. Obviously, there's drugs that can help in several different ways. So some decrease high preloading by promoting fluid loss by the kidneys. So they'll make you urinate a lot. These are what we call Lasix a lot of times. So that decreasing blood volume decreases cardiac output. They could increase the heart's ability to contract. So increasing contractility would increase stroke volume. And they can decrease the afterload. So basically they're helping decrease blood pressure so the ventricles don't have to overcome as much when they are ejecting blood. Some cases, if none of this works, the person's still having problems getting proper oxygen and nutrients and waste to and from body tissues, then a heart transplant might be needed. Or if it's caused by an inability of their heart to try to regulate this, they might put in a pacemaker, which is basically an artificial sinoatrial node, to see if that might fix the problem. Okay, so to review, the amount of blood ejected from either ventricle in every minute. So this is milliliters per minute. That is cardiac output. Your stroke volume is how much per beat. End diastolic volume is how much at the end of ventricular relaxation. Afterload is the resistance the ventricles must overcome. And of course, heart rate is how often the heart beats. Stroke volume at rest is what percentage of the end diastolic volume. That's 50 to 65%. Again, you want your body to have a great ability to increase during sympathetic responses. The Frank-Starling law of the heart has to do with, looks like this got messed up a little bit. It should be, the Frank-Starling has to do with the more the heart is stretched pre-contraction, so basically the greater the preload, the greater the contractility, the greater the ability to force blood through the cardiovascular system. Cardiac reserve would be lower in a well-trained athlete than a person that doesn't move. That's false. So the well-trained athlete, their heart is very strong. So they have the ability to much greatly increase cardiac output safely than a person who does not exercise. Which of the following statements is false when we're looking at heart regulation? So at rest, parasympathetic stimulation predominates. That is true. Thyroid hormone and glucagon decrease the heart rate. That's false. They increase the heart rate. Sympathetic stimulation triggers the release of norepinephrine. That is true. Resting cardiac output in a well-conditioned athlete is about the same in a healthy, untrained individual. Again, this is how much blood per minute. How much is the same? However, so again, to get cardiac output, we're looking at heart rate and stroke volume. So to get the cardiac output, they can have a lower heart rate because their stroke volume is naturally very high.